I'll be your host. Dr. Salim Taye, a clinical care and training lead at CareEpilepsy Ethiopia. And it's a pleasure to have Dr. Etsegenet, neurologist, epileptologist, and advocate for epilepsy care in Ethiopia for today's presentation. Dr. Etsegenet was born in Ethiopia and immigrated to the US as a child. She obtained her medical degree from Wayne State University School of Medicine, and she completed her neurology residency and epilepsy fellowship at the University of Pennsylvania. Dr. Tizazu had a lifelong interest in advancing the treatment of epilepsy in Ethiopia. On behalf of CareEpilepsy Ethiopia, she has formed the first functional international Bureau of Epilepsy in Ethiopia and formed partnerships with other organizations. Thank you, Dr. Etsegenet, for having us and for attending our presentation, for being the speaker.
Thank you, everyone. So thank you for attending this talk. So today, overview no mihono, talking about just like an introduction into epilepsy. And then, kasi buhala demo, we'll talk about like other things like pediatric epilepsy, medication, status epilepticus treatment, so on and so forth. So yeah, learning objectives for today, we're going to talk about improving seizure and epilepsy recognition, distinguishing between provoked versus unprovoked seizures, distinguishing between focal versus generalized seizures, learning to manage and identify the first unprovoked seizure, and learning to manage epilepsy. And then finally, we'll talk about providing psychosocial counseling to families regarding seizures and epilepsy. So first, I want to say thank you to Dr. Archana Patel and Dr. Danny Becker for sharing their slides, which kind of serve the basis of this presentation. So epilepsy epidemiology, so approximately 50 million people worldwide have epilepsy, and the majority, so approximately 80%, live in low to middle income countries. There are approximately 25 million people in Africa who have epilepsy, and about 75 to 94 of those people don't get any medication treatment. And that could be because of stigma, lack of neurologists, and just doctors in general. And just, kind of like the misunderstanding of the epilepsy in society in general. And then this is obviously the highest problem in rural areas because there's no access to treatment in those areas. As you all know, mortality in people with epilepsy is 2 to 3 times higher than the general population, but also important to note that with appropriate treatment, 70% of people with epilepsy can be seizure-free. So what is a seizure? So a seizure is a symptom of a brain dysfunction, right? So we always talk about like a seizure is something that where you do the same thing each time it happens, right? So they're involuntary and they're very stereotyped, and they are indicative of dysfunction that happens in different areas of the brain. They're caused by abnormal electrical activity or overfiring of the neurons. I'm sorry, did somebody say something?
No, doctor, continue.
Okay. So how do seizures occur, right? So for some of us, we know that there's normal brain function here, kind of in the middle, and there's excitation, so things that cause the brain to overfunction or become overly active. And then there's inhibition, which kind of allows the brain to be not overly active. And it's the balance between the two that gives us the normal brain function. When there is an overactivation, so too much excitation or too much glutamate, then that's when we see seizures happening. And then when there is too much inhibition, right? So I guess this is a better point to make, right? So here, when we're all happy, it's a good balance. And then when there's more inhibition, meaning more GABA, then that's when we talk about initially it's sleep, but then coma or death. And then on the other side, when we have more glutamate, that's when we're kind of like when we are arousal, awake. A little bit too much would be epilepsy. And then obviously if there's overexcitation, that can lead to death as well. And so seizure is kind of caused by the off balance between the two states of the inhibition and the excitation. But what actually happens to make this process happen is not really very well known. But in general, both glutamate and GABA are neurotransmitters, so which are chemicals that our body produces in the brain, and they kind of control the flow of ions in the neurons. And again, like I said, it's the disequilibrium between the two that can often lead to like abnormal firing, and then abnormal firing can lead to a seizure. So we have a patient who comes in with a seizure, right? The first question we should be asking after, like, is this a seizure or not, is this a provoked or unprovoked seizure? So what does that mean? So a provoked seizure is a seizure that happened as a result of something, as a direct result of something. So an example of that would be if somebody came in with low sodium, low sugar, if they had meningitis or encephalitis, if they had a seizure as a result of the first presentation of a stroke, if they had head trauma that caused them to have hemorrhage, or like alcohol withdrawal, those types of things are provoked. Why are they provoked? Because they were caused by something else, right? So like electrolyte imbalance, or an acute um, thing that happened in the brain, right? And it has to happen in close temporal relation to the brain insult, right? So like, for instance, if we take meningitis or encephalitis or even stroke, if it happens within 2 weeks of patients experiencing that, then it's provoked, right? But if it happens 10 years after or even 2 weeks after, then it's not provoked, right? So it has to be directly caused by something, and it has to happen in close proximity to the brain insult that happened. And so provoked seizures can happen in any age group, obviously, right? Most infections, so like systemic infections, don't cause seizures, right? So you can see people who have sepsis, and they don't necessarily need to have seizures, right? But if the patients have, brain infections, then obviously that can lead to seizures, right? Um, and we'll talk more about this, but kind of getting into like the febrile seizure group, right? So if you have a patient or a child who presents with fever and seizure outside of the age group for febrile seizure, which is 6 months to 6 years, then we have to look into NLP, because that tells us that the brain has to be involved, right? Because we know that systemic infections do not lead to seizures. So the treatment for this is diagnosing and treating the underlying disorder. And like I said, many brain insults can lead to symptomatic epilepsy later on, right? And so patients can have febrile status epilepticus, and over time that can lead to some scarring over of the mesial temporal lobe structures, and then that can lead to seizures. Cerebral malaria can lead to epilepsy, as well as some neonatal injuries that causes brain damage. And you talked about strokes, and then even some infections, right? So oftentimes if patients have had like meningoencephalitis or encephalitis or meningitis, those can lead to scarring that can form seizures in the future. And an important point to consider is that epilepsy can occur months to 2 years after the first insult. And so even if you have like, a patient who presents with febrile status epilepticus and they don't have seizures anymore, does that mean that they're not going to have seizures in the future? We don't know, right? So we have to kind of counsel them that there's a risk of having seizures, and then also monitor clinically. Now, getting to the unprovoked seizure. So an unprovoked seizure is a seizure that happens without a clear provoking factor. So it doesn't have all of the things that we talked about in the previous slides, that kind of happens immediately preceding the seizure. An unprovoked seizure is a sign that somebody has some sort of instability, like we talked about the balance, there's some instability in the balance between the excitation and in the inhibition, and that leads to instability of the electrical circuit. So it's always a question of, was this just a one-time unprovoked seizure, or does this person actually have epilepsy? And that's something that we always have to think about when a patient comes in with an unprovoked seizure. A focal or generalized seizure, including multiple seizures within 24 hours, as long as they're kind of having recovery between the seizures, is still considered an unprovoked seizure. Okay. So I think we're gonna get to the questions now. I'm not sure why there's this yellow thing here. I do it. Okay. All right, so and you guys can answer. So a 3-year-old child for the first time comes in with a generalized seizure lasting 3 minutes in the early hours of the day, has a high fever, and in the clinic, the doctor says that the child has tonsillitis or an infection of the tonsils. Is this provoked seizure or unprovoked seizure? I'm happy for anybody to answer.
So there is Echo Alyosha answered provoked, likely febrile seizure in the chat. Is that correct?
That's correct, because the patient is a 3-year-old child, and so they're within the 6 month to 6 years range. So that would be a provoked seizure. And what about a 17-year-old man with known history of alcohol abuse who had 2-minute convulsive seizure? His seizure reports he was drunk. So she locked him in the room so he couldn't have access to alcohol for the past 3 days. Is this a provoked or unprovoked seizure?
There is an answer in the chat saying provoked.
That's correct, because it's an alcohol withdrawal seizure.
Yes.
Mhm. All right. So when you have a patient who presents with the first unprovoked seizure, the evaluation again is going to be talking to the patient about, is there some sort of history that tells us that this patient has an underlying epilepsy, right? So it's important to do the history and the physical examination, and then also evaluating for the risk of epilepsy, like does this patient have a history of prior seizures? When you do neurological examination, is there any like focal deficits that tells us maybe there is an abnormal brain structure that can lead to seizures? And is there a family history of epilepsy? And when we say family history, it's not like a cousin or something, right? It has to be like first, like the relationship is like one step removed, like a parent, a sibling. And then are there any concerns for other neurological disorders, right? Like, autism, cerebral palsy, stroke, etc. And then any concerning historical factors for provoked seizures, like, do you use alcohol? Do you use any drugs? Are there any medications that you take, etc. So with the first unprovoked seizure, you have to do like some laboratory testing to make sure that this isn't a provoked seizure, like looking at your blood glucose, sodium, calcium, magnesium, and then toxicology screen, especially if there's a question of whether or not there's a drug exposure or substance abuse history. When feasible, EEG should be performed for all comers, meaning all first-time seizure patients, when the seizure is unprovoked. And that's looking for an underlying epileptiform abnormality, so that can kind of determine the risk of future seizures, or obviously the diagnosis of epilepsy, right? EEG finding should be interpreted with the clinical history to make determination of the patient whether the patient has epilepsy or not, right? Let me kind of make that point. So if a patient comes in and the history is that they passed out, but it sounds like they syncopized or they fainted, I don't really care what the EEG shows, right? Because that person does not have epilepsy, right? Because in order for you to have epilepsy, you have to have had a seizure, right? And syncope does not count as a seizure. So that's the point. So clinical, obviously, so clinical diagnosis of a seizure has to be consistent with a seizure. And then the EEG, if it's positive, right? Meaning if there's epileptiform discharges or seizures captured, then that gives you a diagnosis of epilepsy. EEG is not always helpful, meaning there's plenty of patients, like over 50% of patients who have epilepsy, whose EEG is normal. So a normal study does not exclude epilepsy. And as I said, epilepsy, seizure and epilepsy by definition is a clinical diagnosis. And so the EEG testing is not necessary to diagnose epilepsy, nor is it necessary to initiate anti-seizure medication. So once we kind of diagnose the first unprovoked seizure, and we talked about, potentially doing the EEG, the other thing that we would recommend doing is neuroimaging. So, typically, if the patient's like in here, we pretty much do CTs on everybody and then MRIs, outpatient, come up to Wuhala. But I mean, that's obviously limited in Ethiopia. So for instance, if the patient is kind of back to normal, you can just get away with maybe doing CT. But if you're doing physical examination and the patient has weakness on one side, or they're just not returning back to normal after a few hours, then definitely would recommend doing a CT or MRI. Another thing to consider is actually listening to the patient about what symptoms they had and deciding if it's a focal seizure versus a generalized seizure. So if it's a focal seizure or if there's focal EEG findings, then we definitely would consider an MRI because that tells us that there's something abnormal in the brain that's happening that's leading to the seizures. So one unprovoked seizure plus an abnormal EEG or structural abnormality on neuroimaging, so abnormal CT, MRI, that kind of suggests that there is an underlying neurological abnormality, which then kind of gives you a diagnosis of epilepsy, right? And if epilepsy is diagnosed, the consideration for anti-epileptic medication should be based on the clinical circumstances, as we said, right? That's going to be something we're going to always do in neurology, right? History and exam. So all patients should be followed up after the first provoked seizure to see if there have been any recurrence events, and reassess for risk of epilepsy, even if the EEG and other evaluations were normal, right? So I see this all the time in my practice, right? So if a patient comes in and says, give a history. I ask all the questions about whether or not they had seizures in the past. They said no. And then I say, okay, we'll do EEG and MRI, both are normal. And then we say there's no utility in starting anti-seizure medication at this point because the risk of recurrence is 25 to 35%. And then that's it, right? But then they come back after having a second seizure. Now they've met the criteria for epilepsy, and therefore that's the time we talk about doing starting anti-seizure medication. And we really don't know which patient is going to do that, like which patient's actually going to have seizure recurrence, right? The one thing that's helpful, and that I always say this, is I think people are not too familiar with it, but if a patient has one unprovoked seizure and that unprovoked seizure happens out of sleep, meaning it's a nocturnal seizure, that person should automatically be started on anti-seizure medication because that's equivalent to basically like someone who has had either 2 or more seizures or 1 seizure plus an abnormal EEG or an MRI, with the risk of recurrence kind of around 65%. So that's the only time where a patient who presents with first unprovoked seizure would be started on anti-seizure medication, even if the EEG and the MRI is normal. So the differential diagnosis for seizures is basically any event that causes impairment of consciousness, right? Or like things that are associated with odd movements, like syncope we talked about. Sometimes people can have like transient loss of awareness because of an arrhythmia. And then that could also be mistaken for a seizure. Then the other one is convulsive syncope, right? So people think that patients who faint and then have some shaking, by definition have seizure is kind of how people think about it, but that's actually not true. And then the other thing is, keep in mind is, are the seizures actually, do they make sense? Meaning like the way that the seizures happen, is it consistent with a seizure, or is it related to stress or, some sort of psychological factor? And does the person instead have, conversion disorder? And then the other one is, sleep disorders. So things that kind of make you move and sleep are oftentimes confused for nocturnal frontal lobe seizures. Um, Transient global amnesia also, it can be confused with seizures as well. So what is epilepsy? So we talked about seizure being kind of basically a sign that there is some sort of, cortical irritability in the brain, um, and kind of being a symptom of a dysfunction of the brain. And then epilepsy, by definition, is basically a disorder of the brain that's characterized by a predisposition to generating epileptic seizures, right? And so this requires at least one epileptic seizure, like we talked about. So again, the history is going to be important. And then 30 to 50% of people who have first-time seizures will have a recurrence. And then most often that happens within the first 6 months after having a seizure, then it kind of gets, lower and lower as you go. So we say like first 6 months to 2 years is kind of the highest period of time for recurrence. Now, does that mean that patients can have seizures? I've seen patients who had seizures in childhood, and then they were seizure free and for like decades, like 40 years, and then they begin to have seizures again. So that doesn't mean it doesn't happen, but it's just less likely. So epilepsy is, like I said, 2 or more unprovoked epileptic seizures at least 24 hours apart, or one unprovoked seizure plus a risk factor, abnormal EEG, abnormal MRI, and like we talked about, a nocturnal seizure also would count in that category. So again, get description from the patient and the observer, talk about what happened. What did the patient feel before the seizure happened? What did the family members or friends see? What triggered it? What happens? Like, is this something that happens at night? Is it something that happens in the morning? How frequently does it happen? How long does it last? And see if there's any evolution of symptoms, right? So, and what I mean by that is sometimes patients say, yeah, the first thing I experience is I have this, nausea, um, and like sense of doom, and then I have deja vu, and then everything becomes far, and then I lose awareness, right? So those types of things kind of can tell you exactly where the seizure activity is starting and where it's going. And also, can give you information about what happens before the seizure, during, and after, again, for localization purposes. And then ask about risk factors, right? So birth history. So was there any complications at birth? Prematurity by itself is not a risk factor for epilepsy, right? But if the um, if the as a child they were admitted to the ICU for months, and maybe there was some concern for intracranial hemorrhage or stroke, and they had seizures. All of those things are important to consider. Developmental history, right? So by definition, it's not that like people who talk later or walk later are at risk of epilepsy, but that's kind of getting to any sort of like developmental disease disorders like cerebral palsy, or like autism, things like that, which have been associated with increased risk of having seizures. And then we talked about the febrile seizures. So the history of the febrile seizures, it's not necessarily, if a patient has a febrile seizure, right, do they have an increased risk of seizures? Not necessarily. If it's prolonged febrile seizure or febrile status epilepticus, then definitely take it into consideration. But not every patient who has had a febrile seizure has an increased risk of seizures or increased risk of epilepsy in the future. And then head trauma, we say severe head trauma, meaning like, was there associated loss of consciousness that happened? And then stroke and any kind of brain infections. And then family history, like I said, kind of just like, first relation. And so the history and exam is key. So the history is going to give you clues as to where in the brain the seizure is going to start or starting. And then I can kind of give you into the clues about, the examination. Are there any lesions leading to the seizures and the abnormal examination. And then the history kind of can give you clues about what the reason is for the epilepsy. And then the description of seizure that you get from the patients and their family can help you decide whether the seizure is focal or generalized, right? And that matters because that's going to guide which medication you pick for that patient. So CT and MRI, we kind of touched upon this earlier. So neuroimaging is recommended if it's possible, right? And you have clinical suspicion. The highest yield for using neuroimaging is for people who have focal semiology. So if you're concerned that the seizure is focal, right? Because again, we want to make sure that there isn't anything in the brain that's causing them, or if they have EEG findings that are focal. Or if you have a patient who's just continues to get worse, meaning seizures are not controlled. This is typically in people who have like intellectual disability or some sort of developmental abnormalities where they just get worse, right? So maybe the kids or the babies were sitting up, but they're no longer sitting up. Or if they used to speak and they're no longer speaking, we want to make sure that, is there some sort of underlying progressive problem that's happening, right? Um, and then remember that every case should always be reevaluated, right? So I've definitely personally seen patients who have been seen by multiple neurologists in the past and diagnosed with epilepsy. And then they come to see me and I say, I don't know if you have epilepsy. And we do the testing and they don't have epilepsy, right? So it's always important to reevaluate because we can always be wrong, right? No one knows everything. And then in terms of which to pick, CT or MRI. So MRI is always better if we can have access to it. The CT is really better if you're thinking of more for like neurocysticercosis, which I don't think is really that big of an issue in Ethiopia. So the EEG basically tells us about the electrical activity in the brain, right? So it can give us information about, is there abnormal electrical activity? And if so, is it in one area of the brain? Is it everywhere in the brain? Is the person, what does the brain function look like, right? So someone with, for instance, like someone with severe autism or something might have an EEG that's diffusely slow, right? So that you can get a lot of information about the functioning of the brain from an EEG. And again, like awake versus sleep versus coma. And then it's helpful for if it's positive, right? And so if it captures electrographic seizures, fantastic, then we can diagnose epilepsy if they've had a clinical seizure. Or if it shows interactile spike or sharp waves, then that also helps with the diagnosis as well. But do you need an EEG to decide if you need to start an anti-seizure medication? And the answer is no, because again, epilepsy and seizures are a clinical diagnosis. So we talked about the classification of epilepsy based on kind of what the reason is for the seizures, right? So unprovoked versus provoked. Another way to kind of diagnose, so that's for seizures, but then when we talk about classification of epilepsy, then we talk about symptomatic, right? So meaning like, is epilepsy as a result of something that happened that people have sustained, like meningitis, stroke, tumor? Is it genetic? And the other part's kind of unknown. So where we can't really identify any abnormalities or any etiology, but the patient definitely has epilepsy. And then kind of further to talk about seizures is, the generalized versus focal seizures, right? So generalized means that the whole brain is involved at once, kind of immediately, and that the whole electrical circuit that is involved in the brain is disturbed. Focal seizure is kind of starts in the abnormal electrical activity starts in one part of the brain. And then it can spread to other regions. It could even spread to the whole brain, and then it can lead to a generalized seizure as well, right? And then both the focal and the generalized seizure can happen with impaired awareness or with preserved awareness. So a generalized seizure, as kind of the picture shows here, is that it involves both hemispheres of the brain, so the right and the left part of the brain simultaneously. It doesn't mean that the seizure starts on both sides at the same time. It could just be that it starts in one region. Maybe like, there's some studies that say maybe it starts in the thalamus and then just kind of like spreads, simultaneously to both areas. And that's what leads to the generalized seizure. And then a focal seizure basically originates within a specific part of the brain, right? Oftentimes, it's not often, but by definition, it's limited to one hemisphere, right? So like the left frontal lobe, the left temporal lobe. And again, the sign and symptom is going to tell you about which part of the brain is actually involved. They can spread to near regions or the brain, or to near regions in the brain, or kind of spread to the whole brain. And then the symptoms that people have, like as a result of focal seizures, right? So you can have a focal aware seizure. In the past, it used to be called simple partial, where you are aware. So like, patients will say like, yeah, sometimes I feel numb on the right side of my body, and then it starts to shake and I can see that my arm and, is shaking, I can't control it, right? So that would be an example of a focal aware seizure with preserved awareness. And then the focal impaired awareness seizure is, kind of the example that I gave earlier, where they say like, yeah, like I have deja vu, and then I don't know what happens afterwards. I just end up in the hospital, right? So kind of the neuroanatomy is kind of basic overview, right? So like, why does neuroanatomy matter? It matters because the seizure can technically happen in any part of the brain. And by that, we mean the cortex, right? We don't think that the subcortical structures actually cause seizures. But the symptoms that patients exhibit can tell you where the seizures are coming from. And importantly, I like to highlight this, seizures have to make anatomical sense, right? So when patients say, yeah, my left arm and my right leg start jerking, that means that both, abnormal electrical activity would have to start in two different parts of the brain, in two different hemispheres of the brain at the same time, right? So that doesn't make sense, right? And so if a patient said that, then I would question, I'm not sure if that's a seizure, right? As opposed to, someone who, like I said, says that, yeah, like my leg just shakes or my arm just shakes, then that would make sense. Um, and kind of, the neuroanatomy is important for a variety of reasons, right? Because we talked about if it's a focal versus generalized seizure, it's going to tell us which medication is going to be helpful for the patient. And then it also helps us with monitoring the patient's function, as we talked about earlier, right? So if we think it's a generalized seizure and the patients are just not getting better and they're getting worse, again, it's going to be indicative of, like, is there an underlying process that we have to kind of consider? Um, So signs and symptoms of focal seizures, we kind of touched upon some of them, right? So you can have motor, so like you can have like the jerks, you can have like stiffening, kind of affecting one part of the body. You can have automatisms where people kind of do this, or like smacking, or rubbing their noses, things like that. Sensory, where they can, like people say like, yeah, I smell smoke that's not there. I taste something strange. You can have people who say, yeah, it feels like I have like rising up epigastric sensation, which people describe as like a butterfly sensation in my stomach. You can have, like we talked about, kind of being confused and not really with it, and altered awareness, and that would be like a dyscognitive seizure. People can have experiential, actually, so like crying seizures, laughing seizures, deja vu is a pretty good one. And then autonomic symptoms, right? People will say like, yeah, like my heart beats really fast, nausea, and people can have like pupillary changes, or like changes in like, or incontinence and things like that because of seizure. So loss or impairment of consciousness, right? So there's kind of, this is kind of important to pay attention to, because so there's different elements of consciousness, right? Controlled by, mostly like the subcortical regions of the brain, but awareness is, kind of ongoing activities. Then they have to have memory, and then the responsiveness, and then the sense of self, right? And a seizure can happen, can affect any of these, basically. This is just kind of going over the ILAE, so the International League Against Epilepsy classification of seizure types, right? So focal onset, aware versus impaired awareness, and then after that is going to be motor versus non-motor, And then, like I said, if it's focal seizure and it spreads to both sides of the brain, then you can have a focal to bilateral tonic-clonic seizure or grand mal seizure, basically. Then there's the generalized onset. So again, with the tonic-clonic seizure, you can have other motor, like myoclonic, tonic, atonic, and then you can have the non-motor seizures like absence or the staring spells. And then there's kind of unknown onset, which people can have kind of like mixed epilepsies. So let's talk about a case. So there's a 35-year-old right-handed man who reports losing track of conversations, can't really find his words, and he loses awareness. This lasts 1 to 2 minutes. At times, the spell is brought on by a particular memory from the past, aka déjà vu. A careful medical history revealed that he had one complex febrile seizure at age 3, and no family members have epilepsy. So does this person have epilepsy? Anybody?
So there's a comment saying, no, he doesn't.
Okay, tell me why. Why you don't think he has epilepsy?
Would you write why, Echo? Frequency of episodes isn't stated.
Do you need the frequency to diagnose someone with seizures though? Or with epilepsy? Are you asking more about like we don't know if he's only had one or more than one? Is that what you're
Yeah, I
saying?
think that's what he's saying, yeah.
Yeah, so it says episodes. And then in the other one it says, the spells, right? So it's more than one based on that. But yeah, so I get what you mean. I think if he only had one episode, we can definitively say he had a seizure based on, again, the clinical description is pretty consistent with temporal lobe seizure. Um, but does he have epilepsy? We could have, we would have said maybe, right? We don't know yet. But because it says that he's had more than one, right? Episodes, spells, then that definitely says he has epilepsy. Um, the other question is, do you think this patient has like focal seizure, generalized seizure, focal impaired awareness seizure, or focal aware seizure?
So I would think a focal aware seizure.
Okay, focal, yes. But look at the first sentence.
Focal with impaired awareness. There's an answer in the comment section.
Yes. Yep, exactly. Focal with impaired awareness, right? Because it says here, 35-year-old right-handed man reports losing track of conversations, right? You only lose track of conversations if you're not aware. And he loses awareness, right? So focal impaired awareness seizure. Yep. And so with focal impaired awareness seizures, patients don't typically recall what they do, right? During the type of a seizure, they're not able to communicate. Sometimes they can hear, but they just can't communicate. They can have behavioral arrest, stare blankly. They can have automatisms or kind of involuntary movements like lip smacking, picking at clothes. They can have like dystonic movements of the hand. Maybe they can reach for things that looks like they're like doing it purposefully, but are kind of not purposeful. And so like the most common type of epilepsy that happens in adults is temporal lobe epilepsy, right? And oftentimes it can be may be related to febrile status epilepticus, like we talked about, and mesial temporal lobe sclerosis. And other times it's kind of unknown, right? There are some genetic, like familial temporal lobe epilepsies that can happen, but oftentimes it's kind of either you have mesial temporal lobe sclerosis or you have unknown reasons for having temporal lobe epilepsy. And the seizures are often focal impaired awareness, like the guy we just talked about, will often have deja vu. And these are the boring seizures, is what we call them. Like the patients just kind of stare, they have behavioral arrest. Maybe they have some movements of the lips and stuff, but oftentimes they don't move around, they don't really do a lot. So that's why they're kind of hypokinetic or boring seizures. The exam is typically normal, although over time, if you have uncontrolled temporal lobe epilepsy, you can have cognitive dysfunction. The EEG typically has normal background, but you can have spike and wave discharges kind of over the temporal region. And then sometimes mesial temporal lobe sclerosis noted on MRI, but the majority of the people have a normal MRI. And the prognosis is sometimes you can control it with medication, other times we can't. And then sometimes if it's helpful, especially in patients who have mesial temporal lobe sclerosis, surgery is kind of what we have them go after they failed two anti-seizure medications. And the chances of seizure freedom after that is up to 80%. This is a really good example of like a temporal lobe seizure, actually. So this is, for those of you who are not familiar with EEGs, so this is like the left, like the left frontal and left temporal lobe leads right here. And this is the right frontal, right temporal leads here. And then this is like the left frontal and central parietal region and occipital, and then the right frontal, central parietal and occipital regions here. And then you can see here, this is kind of just the normal background, right? So this patient, I would say, has a normal background. And then starting from here, you can see a change, right? Like where there's like rhythmic activity here, right? So those are the spike and wave discharges. So it starts at 3 hertz, and then it kind of gets faster, and then it gets more and more involved. And so that would be like a left temporal lobe onset seizure. And then, this is a really good example of what mesial temporal lobe sclerosis looks like, right? So these are your temporal lobes here, right? So that's the right temporal lobe and then the left temporal lobe. And you can see that there is a beautiful shape of the hippocampus right here, right? So it kind of makes them, call it seahorse. But here it doesn't have that beautiful structure, right? So it just kind of looks more globular. And then this is kind of more hyper intense or like whiter than this side. So it doesn't have like the typical architecture, and then it also is more hyper intense. And so that kind of brings up the mesial temporal lobe sclerosis. So if I had this patient and they were continuing to have seizures despite being on 2 anti-seizure medications, then I would refer this patient for surgery, and then we would take out the hippocampus, basically. Okay. And then a 30-year-old right-handed woman describes episodes of shaking and stiffening of her left hand, and that spreads to involve her left leg. These episodes can come out of the blue and typically can last 1 to 3 minutes. She is aware during the entire episode, and sometimes the pain, so the episodes are associated with pain. So what kind of seizure is this? Is this a focal or a generalized seizure? And is this a focal aware or focal impaired awareness seizure?
So we have answer in the comment section. Focal aware tonic-clonic seizure.
Focal aware, yes, but it's not tonic-clonic seizure. Because tonic-clonic seizure by definition is a generalized seizure, right? Because you can't have tonic-clonic and be aware. That means if you have generalized tonic-clonic seizure, both sides of your body are involved. So that means both sides of the brain are involved, right? So I agree that it's focal. I agree that it's aware. But instead of using the word tonic-clonic, this would be a focal aware clonic seizure, because this is basically what the patient's doing. That's clonic. Tonic-clonic indicates like a grand mal seizure, but we're on the same page. Okay, so a focal aware seizure. So you can have the typical that we talk about, like the focal aware sensory seizures or auras, right? So we talked about like the epigastric rising sensation, the impending doom, the deja vu. If you have occipital seizures, you can have like flashing lights. Like in the parietal region, you can have sensory changes. And then the focal aware motor, which would be an example, the patient that we just talked about would fit under the focal aware motor seizure, because they have rhythmic jerking of one part of the body, and that can involve the hand, the face, or the leg, or all three of them. Can start in one region and go up.
However,
Another case.
sorry, doctor.
Mhm.
The one that answered focal aware tonic-clonic seizure asks, what
Mhm.
about the stiffening? How can we explain that?
Yeah, so you can have focal stiffening, right? So let me see if I can go back to right. So you can have, again, focal onset aware and focal onset impaired awareness, and you can have motor or non-motor, right? And so this would be a focal onset aware seizure with motor symptoms. And the motor can be broken down to, again, like you can have jerks, so like myoclonic jerks, and that can be unilateral too. You can have clonic, right? And you can have stiffening, right? And so all of those things can happen on one side. It doesn't mean that the stiffening or like um, the clonic by definition has to come from both sides, right? Does that make sense?
Um, but the stiffening goes with tonic. That's what.
Right. So I see what he's trying to say now. Okay. So what you're saying, shaking and stiffening of one leg, right? And then that spreads to involve, or the left hand, which spreads to involve the left leg. So are you saying, are you calling this a tonic-clonic seizure, or are you saying that the patient has a seizure that causes unilateral tonic followed by clonic seizure? I guess that would be the difference.
Unilateral tonic followed by tonic.
Followed by
Followed
clonic.
by tonic, yeah.
Yeah. So I would take that. That makes sense. I thought you were saying this is like a generalized tonic-clonic seizure.
Okay. No.
That makes sense. Okay. The next one is a 45-year-old man comes in stating his bedtime partner saw his left arm shaking in his sleep. Okay. He woke up feeling like he lifted 100 pounds in his left arm, and does sometimes wake up feeling muscle soreness. Um, so what do you think about this? Do you think this is focal or generalized? Anybody want to answer? Okay. So this would,
Asking onset, the onset of the seizure.
sorry, what did you say? I didn't hear the first part.
The onset of the episode. Someone is asking that.
What's the onset? Well, that's
Yeah,
my question. Is the onset focal or not, is the question.
it's a known onset, so we can't determine.
Okay. Well, let's see what it says. So it says left arm shaking, right? So does that give you more information? Right? So if it's one part of the body that's involved, that would be focal, right? Yeah, so this would be a focal. We don't know if it's, if I think maybe what you're trying to say is that we don't know if it's impaired awareness or aware seizure because no one is telling us information about what he's experiencing, right? But we can say that for sure this is a focal onset seizure because it's only the left arm that's involved. This is a pretty good description of frontal lobe epilepsy because frontal lobe seizures typically happen nocturnally. And that's why they're often kind of mistaken for sleep disorders. Again, most of the seizures are focal impaired awareness seizures, but sometimes they're not. I've definitely seen a whole bunch of patients who wake up in the middle of the night, and experience the seizures, and they can describe to me exactly what they're feeling and what they're experiencing. This is the complete opposite of temporal lobe seizures, in that temporal lobe seizures, again, people are not moving. They're kind of the boring seizure. And then the frontal lobe seizures, kind of people can have crazy movements, right? So they can be like sitting up in bed, get on their knees, and then they can like even turn horizontally during a seizure. And all of that is kind of part of the seizure. So this is the opposite in that sense. Their exam is often normal. EEG is also often normal, would be very helpful to have abnormalities that we see on the frontal lobes, but that doesn't typically happen. And the reason is because the kind of the thickest part of the skull here is kind of what is covering the frontal lobes. And so the leads that are kind of sitting on top of the brain or on top of the skull have a harder time picking up the electrical activities from the frontal lobes. MRI is also often normal, but if I see a patient who's had frontal lobe epilepsy and they're not really getting seizures controlled, then I might, be thinking about like, is there some sort of like cortical dysplasia or some sort of like infection or trauma that they sustained in the past, or like, stroke. Sometimes it's genetic. There's like nicotinic receptor mutations that are related with frontal lobe epilepsy. But this is a really hard epilepsy to diagnose. Patients go maybe 10 plus years without getting a diagnosis because either, maybe they live alone and no one is witnessing what's happening in the middle of the night, or because EEG and MRI and everything is normal, they are often kind of sent to, sleep neurologists to determine whether or not this is sleep related. And then the less common types of epilepsy, we talked about occipital lobe seizures, where you can have visual hallucinations, kind of like, bright lights, spots. Not really like, you're not going to see formed people or animals or anything like that with occipital lobe seizures. They're very elementary hallucinations. You can have gaze deviations, and then most often, if you have occipital lobe seizures, then you have like the eyelid fluttering or the blinking. That's a part of it. And then all of these types of seizures that we talked about, we can cause secondary generalization. We don't call it secondary generalization anymore. We just say like focal to bilateral tonic-clonic seizure, basically. But it can, the focal seizures can start in one area of the brain and kind of involve the entire cortex. And then oftentimes people, start with focal aware, then or focal impaired awareness seizures, and then they have the generalized tonic-clonic activity. And treatment for epilepsy is anti-seizure medications, and that you pick medication based on generalized versus focal onset, and then comorbidities, right? So if I have a patient who has bipolar disorder, then I would say, okay, maybe Depakote or lamotrigine is a good medication so that we can treat both the bipolar disorder and the epilepsy at the same time. And the goal with the treatment is no seizures and no side effects, obviously, right? That's kind of easier said than done, but that's always our goal. So part of the treatment is talking to the patients, educating the patients about why the medication is needed, right? So even in America, I have patients who go to the emergency department after experiencing seizures and they get put on anti-seizure medications. And then they come see me and follow up and they're like, well, I didn't know I was supposed to take the medication forever. Like I thought I was just supposed to take it for a week or for 2 weeks, and then I stopped it or I ran out or whatever, right? So like explaining to the patients why the medication is needed is really, really important, right? So one, you're giving them the ability to make the decision for themselves, right? And also why they need to take the medication, so that it helps with, basically like them being adherent to the medication. Um, so and start the anti-seizure medication that's best for the person's age, the seizure type, and the clinical status, and obviously like medication accessibility, right? And so, for instance, if there's a woman of childbearing age who has epilepsy, right, I would not start that patient on Depakote, right? Because we know that Depakote has been associated with birth defects, right? And then also, talk to them about the fact that epilepsy should not be limiting them from going to school, playing soccer, or whatever sport that they're doing, right? And part of that is kind of getting into the stigma, right? So we have to be the people to work on the stigma, and alleviating the stigma starts with us sharing this type of information to our patients, right? Because we know that worldwide, people with epilepsy are impacted by stigma, discrimination, and human rights violations. And this is obviously true in Ethiopia. And these have consequences for the quality of life, right? And we want patients to be included in the social aspects of life, and not just kind of be excluded from society. And the stigma also discourages seeking treatment, and we obviously are, at CareEpilepsy are working towards encouraging people to come and seek treatment, and kind of get involved, and increase their quality of life, right? And so our responsibility is we are going to improve the knowledge and raise awareness of epilepsy, and we're going to dispel the myths, and then we're going to, and what we're already doing is also improving access to healthcare services, and then improving the quality of life for our people, and in turn our country. So psychosocial counseling is essential to all of the visits basically, but especially the first one, right? So like you have to explain to them, like we say, okay, yeah, you have seizures, you have epilepsy, but what does that exactly mean, right? And we have to talk to people in terms that they understand, right? So you can say like, yeah, like a seizure is caused by excessive electrical activity in the brain. It's not caused by, like a curse from God or anything else, right? And then tell them what actually causes it. We have to say that seizures are not contagious, and seizures, just like, um, people can develop diabetes or high blood pressure at any point in their life. Seizures can happen the same way, right? Because it's a medical um, disorder. It is not like a curse or anything like that, right? And so it's a medical problem, and it should be treated as one, right? And then importantly, like making the point that people can still participate in activities depending on their baseline functioning level, obviously. And then providing kind of guidance on seizure first aid. So what happens, what am I supposed to do when a seizure happens, right? So if I were caring for someone who was having seizures, I would want to know this information, right? So I think a lot of the times I have not personally experienced anybody who have a seizure, like who've had a seizure in Ethiopia, but I've definitely talked to my parents and my husband about it. And there's this match thing. I think he said like they light up a match and they put it under the patient's nose or something, and that's supposed to bring the patient out of um, a seizure or something, which obviously should not happen. We should never put anything near them that can burn them or cause any injury to them. We should never hold them down. We should never put anything in their mouths, and just kind of stay with the person until they wake up. And I've heard some stories about people believing that if they touched someone who's having a seizure, then the seizure, the epilepsy is going to be like passed down to them, and that's obviously not a thing. Um, And then again, going to like the seizure safety. So like driving obviously should be avoided until the seizures are controlled. And then people with epilepsy should not do like excessive alcohol, right? And then, sometimes obviously working on sleep deprivation. Um, Sometimes patients have epilepsy that's sensitive, especially if it's occipital lobe seizures with like flashing lights. And so kind of avoiding those places and those types of patients. And then just, kind of having community programs, right? Always encourage people to go to school, right? Your epilepsy doesn't make it so that you can't attend school. And remembering that epilepsy is scary, right? So I've, seen, I don't even know the number of seizures that I've seen patients have, but I've seen plenty. And it doesn't get easier with each time, right? Because each time it's still pretty scary, right? So, like the patient kind of looks like they're not breathing, and they kind of look like they're kind of like it's kind of it's very scary, basically. And so tell them that, yeah, like it is scary. It might not, maybe it gets better over time, but maybe not. But that, they have a plan, right? So we're gonna treat their seizures, and then kind of teach them about the first aid and what to do, and that kind of empowers people to feel more comfortable. Um, right. And then, yeah, many people with epilepsy can lead normal lives. And patients kind of need to hear that. So making sure to talk to them about that as well. And I think that's it for me. Um, any questions or concerns that people have?
There's a question in the comment section. It says, is it possible to stop anti-epileptic drugs at some point of a patient's life?
Good question. So we say that if a patient has been seizure-free for 2 years on anti-seizure medication. So, and when we say seizure-free, we mean like all seizures, right? So even auras are seizures, right? So none of that for 2 years, then we can consider taking them off of anti-seizure medication. Now that's different for each people, right? So if it's a person who, for instance, like, you got an MRI and the patient has mesial temporal lobe sclerosis, then no, that patient cannot come off of anti-seizure medication. But if it's a patient who has had, clean imaging, so meaning like there's nothing on the brain that we can say, oh, this is what the seizure is caused by, then we can consider, taking them off of anti-seizure medication after 2 years of seizure freedom. The risk of recurrence doesn't go down to zero. The risk of recurrence is typically around 45% for all comers. And that risk of recurrence is obviously higher if, they've had an abnormal MRI, an abnormal EEG, or like a nocturnal seizure, basically. But I do take patients off of anti-seizure medication after 2 years of seizure freedom, if all of their workup is normal.
I have another question. We had a patient at CareEpilepsy Ethiopia with medial lateral sclerosis, and he had focal epilepsy. But after about 1 year, the MRI was repeated and the results were normal. Can it happen? Because no intervention was done for this patient.
Yeah, no, that can't happen. It means that either the first one was wrong or the second one is wrong.
Yeah, all right.
Yeah. So mesial temporal lobe sclerosis, by definition, that means that there's like scarring that happened, and the scarring is not something that goes away, right? We all know that brain doesn't heal very well, right? Um, so it can get worse, but it can get better. Even if we control seizures, it's still going to be the same. I will say that um, mesial temporal lobe sclerosis can be tough to diagnose if your MRI is not it's not if it's not done correctly, like if the patient's moving, right? Because sometimes, especially if it's on the left side, for some reason, the left temporal lobe like picks up the hyperintensities in MRIs, and so oftentimes people will misread the MRI as showing mesial temporal lobe sclerosis, but that's why we don't just rely on the hyperintensity, right? So it's hyperintensity plus the architecture, whether or not there's normal architecture or not. So it has to meet all of those criteria. So I would say one of the two is wrong, either the first one or the second one.
All right, thank you, doctor. Is there any question among participants? So I would like to raise some questions asked when our participants fill the form for registration. Can we say some things about absent seizure in adults?
There is no such thing as absence seizures in adults,
All right.
unless they started with having seizures like in childhood. So like, let me back up, right? So you can have epilepsy onsets in adults. So like, after like adolescence, and they can have focal or generalized seizures. But those patients do not have absence seizures. So absence seizures is something that happens. It's by definition a childhood epilepsy, right? So like I have patients who are adults who have absence seizures because they have, they've had seizures in childhood, but you don't develop absence epilepsy or absence seizures in adulthood. I think when people refer to absence seizures in adults, they're referring to the focal impaired awareness seizures. But obviously that's not a correct way of talking about it.
So there's another question. Will an epilepsy relapse after being treated for 2 years?
Sometimes it does, yeah. That's why I said like it does, the risk of recurrence doesn't go down to 0. It's 45%, and that's the highest within, you know, the 45% risk is highest within the first 2 years. But I've personally seen patients who've gone like, you know, decades, 40 plus years without having seizures, and they all of a sudden have seizures again, right? And we don't know exactly why that is, right? But it does happen.
All right, thank you. Any other question, everyone? Okay, so I think we can wrap up. And as we wrap up today's session, I would like to extend our heartfelt gratitude to you, Dr. Etsegenet. Dr. Etsegenet is a neurologist, epileptologist, and advocate for epilepsy care in Ethiopia. And she has a medical degree from Wayne State University School of Medicine, and she completed neurology residence and epilepsy fellowship at University of Pennsylvania. Dr. Tizazu had a lifelong interest in advancing the treatment of epilepsy in Ethiopia. And on behalf of CareEpilepsy Ethiopia, she has formed the first functional international bureau of epilepsy in Ethiopia. So for those of you who weren't available at the start of the webinar, CareEpilepsy Ethiopia is a nonprofit organization dedicated to supporting individuals with epilepsy and their families through education, advocacy, and healthcare services. So education is this webinar is part of the education that CareEpilepsy is doing to create awareness for epilepsy. So I think today we covered important points such as introduction in pathophysiology of seizures, provoked and unprovoked seizures, other classification of seizures such as generalized, focal aware, focal with impaired awareness, and such, and epilepsies arising from different lobes in their presentation. And we highlighted on treatment, and we had a Q&A session. It was a very informative experience. Thank you everyone for joining us today. You can stay tuned in for more sessions since we have this monthly webinar every month on different titles, and almost all of your questions will be answered on those sessions. Dr. Etsegenet, thank you so much once again. See you in the next sessions.